I want to extend a very warm welcome to our Honorable Minister of Health, Young Berhormat Dato Sri S. Subramaniam. Your understanding and clear support for our cries for health was noticed by the powers that might be, and some concessions were eventually made. Even in the last budget, announcements late last year, there were some further concessions, and we know, Dato Sri, that you had a silent role in pushing for this. We thank you, sir.
Yang berbahagia Dato Dr. Jacob Thomas, President of APHM, Dato Amiruddin Abdul Sattar, Vice President of APHM, Puan Sushila Devi, Deputy CEO of Martred Malaysia, Puan Shireen, CEO of Malaysian Healthcare Travel Council, members of the foreign embassies and foreign missions, speakers who have come from various parts of the world to enrich in this Congress, members of the press, ladies and gentlemen. First, I would like to congratulate APHM on this 24th convention, International Healthcare Conference and Exhibition, which you're organizing, and like what Dr. Jacob Thomas said just now, next year will be their 25th anniversary, a major milestone for private hospitals in Malaysia and for the contributions they've done towards healthcare in the country as a whole. And I also would like to thank Dr. Jacob Thomas. I didn't intend to offend him last year when I told him not to make a policy speech. But having actually made a very concise presentation of the state, the affairs and the needs of the private sector at this present moment in time. Needless to say, ladies and gentlemen, the private sector in Malaysia has contributed tremendously in a synergistic form towards the public sector in the delivery of healthcare. And if you look at the Malaysian healthcare system in the current scenario, we have a lot of achievements. I was in Geneva last week attending the World Health Assembly, and it is actually nice to note that amount of international recognition which has been given to us in the process of healthcare. And there are many countries in the world who are looking towards our experience, our expertise, and the way we have delivered our healthcare system from independence to now. So this is a great achievement. I think, needless to say, Malaysia has been recognized as one of the best health systems in this part of the world, having good outcomes, and having solved most of the fundamental aspects of healthcare. We have reduced infant mortality rate to a very a level which is highly appreciated. We have reduced maternal mortality rate to a level which is highly appreciated. We have got very strong child health facilities in our public sector. Every Malaysian has got a health facility within 5 kilometers of where they live, even in the remotest of villages. And these are all achievements which very few countries in the world have actually achieved. And this is very important because once we have got the infrastructure and the network of health system, then it allows us easy access to the people as large in the implementation of policies pertaining to health. Well, that's all the good points. Of course, we have got our challenges. The challenges of the healthcare, of course, is the long-term financial sustainability of the healthcare system, particularly in the public sector. As you all know, if you take the expenditure towards healthcare as a whole in the country, that's what Dr. Jacob Thomas said, that we spend about 4 to 4.5% of our GDP on healthcare, which of course is more or less the same as most other countries in ASEAN, except for the more developing countries, the countries which are just developing, like Vietnam and Thailand, which tend to spend a bit more on GDP than we do. But compared to the more developed countries of the world, like Europe and America, of course, our expenditure of healthcare on GDP is still considerably less. I have said that we probably have to spend 6% of GDP on healthcare to ensure the financial sustainability of our system in the long term. And of our total expenditure of healthcare, 55% is by the public sector and 45% is spent in the private sector. And the unfortunate part of expenditure in the private sector is a bulk of this expenditure is what we call out-of-pocket expenditure from the patients themselves. If you ask any person, any health economy, they will say out-of-pocket payments are not good ingredients for the long-term sustainability of the healthcare system. Our figures last year showed that about 35-36% of total health expenditure is out-of-pocket. And that leads to what we call potential health catastrophes, because there could be situations where people are ill, but they don't have enough savings to meet up to the expenditure of that. And this is a challenge which we have to meet. And according to reports from WHO and other agencies, any country in which the out-of-pocket expenditure is more than 15 to 20% has got a greater risk of leading to health-related financial catastrophes. So taking this into mind, we have to find some solution by which we can reduce this out-of-pocket expenditure by patients. That being one challenge, the other challenge is, of course, the demography of our population. We are slowly becoming an aged population. Lifespan of Malaysians is now reached about 74 years. More for women, I think about 77, 77.3. Lesser for men, about 73. Averaging about 74, 74.5. This has got its challenges. As people become older, they tend to use healthcare facilities more. And yesterday in the World Economic Forum, on a panel on universal healthcare in which I was participating, one of the speakers brought this issue that in private health insurance, studies show that bulk of the expenditure through private health insurance actually goes towards the last 15 years of life. So these are challenges which we will face as time goes by, when people tend to spend more and more money towards the later part of life. So if your age is going to be 75, then you're starting to spend after the age of 60. That's when the peak of healthcare spending comes. And the unfortunate part of it, that is the part when your income and the ability to generate income is the least. So the expenditure of health peaks at the time when your capacity to generate income is the least. So how do you manage this duality of this healthcare phenomenon? That's a challenge. So these are areas in which we also have to look into. And to add to that is the burden of diseases which we are facing. Our National Health Morbidity Survey for 2015 is ready. I think next week I'll be having a media conference on that. Probably we should invite the private sector to participate in this, to know what are the problems as far as we face as far as morbidity goes. We have got very unfortunate figures. The prevalence of diabetes of about 17.5%, out of which we think about 9% already diagnosed, 8% undiagnosed. They are in the community having diabetes, not knowing their diabetes. We have got about 30% who are hypertensives above the age of 18. And we have nearly about 17.8% of Malaysians obese. By the definition of obesity, that is 2 standard deviations above the BMI. And we have got nearly another 30% who are overweight. That means after every 2 Malaysians, 1 is either overweight or obese. And that is not something which is good for the demography of a country. And you know what are the repercussions of the health consequences of the nation. And we have got nearly 47% of those above 18 whose cholesterol is higher than the permitted level. So these are very, very big challenges. You've got an obese, high cholesterol, potentially high diabetic nation. So how are you going to meet up to these challenges? Because this is where the future health problems are going to come. So in our health challenge will be how you're going to manage this chronic diseases. And all our evidence shows that the management of the chronic diseases in the private sector compared to the public sector is not all that satisfying. The reason is the person who chooses, that's mainly in the primary care of the public sector, private sector, not so much in the. There will be a small percentage who probably use the private hospitals as choice managements for chronic illnesses. But once out-of-pocket payment is a mode upon which they're going to seek treatment for chronic diseases, then the tendency for the patients to use the facility is when they have money and not on a regular and continuous basis. Because of this singular setback, our study shows that the continuity of healthcare to allow for optimal management of chronic diseases in the private sector is still far from satisfactory. Whereas in the public sector, you don't have the burden of payment on your shoulder. There is a greater compliance, and the key results which we are seeing shows that there's better outputs and better results in the public sector. So this is a challenge. So long as the mode of payment continues to be out of pocket in the private sector, then we will be always faced with the non-efficient management of chronic diseases in the private sector, which will lead to greater complications as years goes by. This is another big challenge. So against this background, I think we are, of course, like what Dr. Jacob Thomas see, how are we going to sort of synergize both the private and public sector? And we are working on some kind of major transformation, and we probably will be making announcements of this and having discussions with you as time goes by, so that we can try to optimize the facilities which are present both in public and private to ensure that we can manage the challenges of our health system in a much more optimal and a much more better and efficient manner. So, in the private sector, I probably will request upon you a few things. One is, of course, can the style of management in the private sector hospitals change? For example, there are very few private sector hospitals which are based or designed on a specialty unit basis like what we do in the public sector. For example, in the public hospitals, we got a medical unit. There are a lot of people who work under the medical unit as one team, supporting each other, synergizing each other, and helping us in producing outcome. In the private sector, the way it has evolved in Malaysia, in distinction to private sector in countries like Taiwan, Japan, Korea, for example, is we have evolved along the private individual practitioner concept. So every doctor in the private sector in Malaysia is an individual. He's not only as a person, he's individual, he's also an individual company in most of the setups. So being individual companies, multiple individual companies practicing under one setup. So the synergy which they can get out of cooperation amongst each other as a team is not met. So whether a different kind of model can work in the private sector, where this teamwork between members of a similar specialty can be augmented to produce better results, is something which you have to think of as we move forward. This is very, very important. And that will allow probably greater efficiency and also greater degree of utility of facilities. And because of this, we see there is a lot of multidisciplinary management of a single patient with extra costs. For example, if a patient goes to a private sector, in a public sector, a general physician will try to manage the diabetes, the hypertension, and all aspects of the patient. There won't be multiple management. Whereas in the private sector, the moment a cardiologist sees a diabetes, he immediately refers to his endocrine friend and not try to manage the diabetes. It's not that the cardiology is not capable of managing diabetes. Every doctor is able to manage diabetes. That's what you're trained for. But the way the system has evolved is that immediately diabetes, you refer to the endocrine. Hypertension, you refer to the cardiac. Asthma, you refer to the respiratory physician. So at the end of the day, a patient who probably will be managed by one doctor in the public sector lands up to be managed by 5 doctors in the private sector. So this, of course, extra costs. I know this is a very thorny issue, but I'm just throwing it out. So this is a thorny issue. So, but it adds to costs. It adds to costs. And extra costs. And that is one of the things why the cost of healthcare in the private sector continues to go up. So these are areas in which you might want to transform, whether you can re-look at the model and whether you can actually transform this. And probably there is also a need for private hospitals, this will be very challenging, big challenge, to audit on unnecessary utilization of facilities and unnecessary prescriptions. Whether you can do that. I'll give you a classic example. This happened to a friend of mine very, very recently. He was admitted to a private hospital. He had gone to India recently, but 2 weeks prior to that. Admitted to the hospital with hepatitis, very high liver enzymes. And during the course of the treatment, of course, an ultrasound was done and gallstones were found. If all of you do ultrasounds, I think 90% of you will find gallstones in your ultrasounds. All of you who are sitting here healthy, you will find gallstones. So gallstones were found in the person, and then the doctor says you got gallstones. Maybe all these problems are related to the gallstone. So this guy asked me. I said, I looked at the enzymes and said, I don't think this is due to gallstones. And anyway, by waiting for 1 week or delaying the need for removal of the gallstone, the doctor actually prescribed removing the gallstones. You won't lose anything by waiting for a week. And he told me, just wait for the week and repeat the enzymes. And lo and behold, when you repeated the enzymes dropped. So just listening to the advice of the Minister of Health, he actually saved himself probably 70,000-80,000 ringgit. So, are you going to audit this kind of practices? Where, obviously, dictated by the profession and the science of medicine, such decisions are definitely wrong decisions. But it going on, there probably has got to be some kind of audit on these abuses. Prescription of more expensive tools where you can solve a problem by a CT scan if you got to do an MRI. Just because you got a higher MRI of the highest order in your hospital. So these are challenges which you have to look at and put into, and I strongly believe there's a case of audit on practices, like what we do now in the public sector. We repeatedly auditing everything which we are doing. There is a need for similar kind of audits in the private sector, so you can actually make sure there's no abuse of the system, because this individual makes his decision. Individual makes his decision. And that is not subject to any kind of scrutiny either by peers or by any other person. So there's a need for this kind of audit to actually put this thing right so it will be okay. And in the Ministry of Health since last year, I have started what we call an evidence bank. So under the National Institute of Health, we got one of the departments which collates all evidence on all aspects of medical practice. So I have told this department that any decision which I make or any decision which the ministry makes should be based on evidence. We are living in a world of evidence. And we are also living in a world in which technology is available to collate, compute, and analyze this evidence. And there's tremendous amount of tools available. So we should be dictated by evidence. Our actions, our decisions should be dictated by evidence, because there is tremendous amount of evidence available. And this is an area which you might want to also look at, whether the current practice which is being followed is backed by evidence of peers all over the world. And this is an issue which we have to do, because eventually that is what it's going to be. And with the availability of big data, I can foresee you will be able to have something which you never did before. This is an information which you never had. But now we have got these tools which can actually do this for us. And we can use this for the purpose of analyzing information, producing evidence which can be our guide in making decisions. This is very important. Decisions made by perception. Of course, we have grown away from those days. I mean, if you listen to the consultants, I had consultants who say, I walk into the ward, I can smell typhoid. I mean, that is where we lived. But nobody would have done a case control study whether the smell is actually typhoid or not typhoid. But it was an age of perception, and we were dictated by perceptions. But we have sort of grown out of the age to an age in which now we are guided by evidence. So we have to use evidence as the basis of whatever decision which we are making. And private hospitals have to move in that direction, so that not only for you, in terms of cost, is going to help you, but in terms of the level of the practice, it's also going to be something which is very, very important. And it's very important because just 1 month ago, 1.5 months ago, I was in Tokyo attending a roundtable conference of ministers of antimicrobial resistance. It's frightening. It's frightening. The area of antimicrobial resistance is frightening. And last week, America reported a lady with urinary tract infection with a so-called superbug, which was not responsive to any of the antibiotics which they have. And that kind of situation is exceedingly frightening if you don't control the prescription of antibiotics within the private health sector, along with the public health sector, in which we have to join together and work, so that we can actually address this issue based on evidence, which is very, very important. So these are the challenges which we have, so that we can actually look at it and try to work towards to try to solve this problem. And in the economics also, whether we can reduce the cost of drugs, reduce the cost of investigations. These are challenges which we have. And in the area of health tourism, we are trying to be as supportive as possible. There has been this request, that we must allow some leeway in the fees which is prescribed for foreigners, so that could sort of be an incentive for doctors for wanting to see foreign patients as a mode to boost health tourism. We want to boost health tourism because, like what Dr. Jacob Thomas said, that Malaysia is recognized as a center for health tourism, and you all have got the capacity to do it. And countries like Thailand are doing better than us in that area because they have had a more focused approach to that whole problem, and they have created services which sort of are very attractive to bringing foreign patients to some of the hospitals. So we are discussing on whether it's possible to provide some kind of flexibility in the professional fees would be charged by doctors for managing foreign patients. We might not call it professional fees, we might call it a processing fee, or facilitative fee, or an administrative fee, which will be on and above the normal professional fee, so that will be as an added incentive for doctors who are managing foreign patients other than local patients. We hope with that kind of change, that will give you some incentive to manage foreigners, but not at the expense of locals. Your first priority, of course, is managing the locals. And if you've got extra time, then in which you want to manage foreigners, that should be something which we will support. And among the points which were raised by Dr. Jacob Thomas on the approval of designs and structure for private hospitals, I'm quite open to the idea of using pre-prescribed architects who have got the knowledge and the designs which are required by the Ministry of Health. And this is done by other agencies in the government, for example, local government doing it in the building approvals. So I think it's something which is possible. I think we should take up this discussion with Bagian Amalan within the Ministry of Health, so that these issues can be addressed. I don't want the Ministry of Health to be restrictive in its approach, which delays time and at the end of the day increases cost. So these are some changes which I think we can work together in trying to improve the management of health services. The last point which I would like to raise is the interaction between private insurance and managed care organizations. Although private insurance provides payment, there is this concern even in the insurance sector that there's a differential in which private hospitals treat patients who are paying out of the pocket and in those who are actually paying insurance. And this is something which you have to look at. I think just because the payment is by an insurance company and not by the individual, and just because of that we feel it's an opportunity to actually charge more. But at the end of the day, we are contributing to an overall increase in health costs, and that will have its repercussions on the entire management of the health system. So this is an issue which you have to see, that there's objectivity in the management of such patients, and there's no tendency for doctors just because of insurance to do things more than what they would do if the patient is actually paying out of his own. So there's a similarity and a congruity of such managements. And this is some issue which you have to manage. The other extreme is managed care organizations, and not so much for private hospitals, but for primary care physicians in the private sector. I think there has to be some kind of unity among this group of people to ensure that they don't go into very unprofessional contracts with managed care organizations. I know some general practitioners who agreed for consultation fee for 10 ringgit to MCOs. This is unrealistic, it's ridiculous. My barber charges me 40 ringgit. So how can a doctor go into a contract for 10 ringgit? Because the net result of this is in the quality of the management which they eventually give. So when they start cutting corners because of these negotiated deals which they've done with managed care organizations, which I consider actually sinful, and which at the end of results leads to very poor care, because you have to cut the cost somewhere, and leads to a very unfair competition among those who are practicing, and which makes it very, very difficult for those who want to practice good medicine in that kind of circumstance. So it beats away the good fellows. And this group of people who just want to earn a living through MCOs start functioning. That's not right. These are areas which we have to look at. These are challenging areas, but I hope you will look into those areas. I've raised a lot of points out of them, but these are all things which have got some truth in it. So think about it, see how you're going to deal with it. Because as we go towards better private-public partnership, at the end of the day, the cost within the public sector and the private sector should be more or less similar for this private-public partnership to work out, be efficient and be healthy. So for that reason, we need to see these challenges, rectify it, make it right, so that eventually when we actually have got a healthy and an effective public-private partnership, this will be possible. Because we are doing some, I can give you some clues, some of the direction in which our healthcare transformation is going eventually will shift a lot of patients from the public to the private sector for wanting to share the resources in the private sector. But when that happens, of course, cost, efficiency, and doing the right thing will be the factors which will determine to what an extent we can do this. With those words, I've got great pleasure in declaring open your 24th APHM International Health Conference.